things or leave make a pause in the work or go in between from two hospitals, and other is free time and family time and are here. So thank you. So hola Manuel, hola Jacobo. The idea is to discuss different issues from Coma. So I will start with some question, and other may probably Claude or other people, each of you can do another question. So the first question, hola Brenda. The first question is.
Hola Walter, saludos.
Hola. Can we talk about the different ideas about how we approach to the coma patient, the comatose patient, from the medical side, nurses side, and after family? If we can start to discuss. So the first person, Giselle, after Cassie, after Brenda, after the rest of you.
Okay, Walter. So I think one important thing, especially in our countries, is to make sure that families do understand what is coma. I think there is a big confusion when we have patients in the ICU, because many of them are receiving medications to be sedated, but are not on coma, and sometimes the families don't understand this. And I guess that you have to make it real clear, because sometimes, the idea that they are, not aware or they are not awake can come because they are receiving a medication, might confuse the family, especially about prognosis. So I think as a community, we have to, just like we did with many different diseases like stroke, we have to teach people on what is coma, what are the diseases that can lead to coma. And I guess that nurses have a great opportunity because they are closer to the patients and to the families. They stay there more time than physicians do. So I think that using the same words, from all medical professionals, teaching families and having them understand what coma is, it's a very important first step, to start talking with families and with lay people about coma.
Okay. Cassia?
Hello, good morning, everyone. No, so I think in Brazil, we have a problem that's a self-fulfilling prophecy. We still have self-fulfilling prophecy in many, many hospitals. So it's getting better with time, but I think that many doctors and nurses and medical professionals still see coma and neurological patients as patients who are, we are not investing in these patients very much because they are going to have many problems if they survive. And I think in Brazil, this is a major problem in many hospitals. And about the family, of course, the family always want to know when the patient is going to wake up. And if they're going to wake up, if they're going to have a meaningful life after that. So I think that neuroprognosis is a real problem. Only in the side of the medical doctors and the medical professionals, and on the side of the relatives and families.
So for complete Brazil also, you are neurocritical care people and came from neurology or ICU, but we have also two neurosurgeons. We have two neurosurgeons from Brazil, Gustavo Patriota and Jorge Paraño. Sometimes also what I learned in Argentina and other countries, when we discuss a patient and related with self-prophecy, sometimes the neurosurgeons are more on the side of nothing to do, whatever. If you want to do something, they say, it's okay, not call me anymore. So Gustavo and Jorge, what is your opinion about this? The approach to the comatose patient. Gustavo, Jorge.
Hola a todos.
Hola, Jorge, sí, te escuchamos.
Hi, everyone. I don't speak in this moment. I am in the center of surgery.
Ah,
I will operate a patient in this moment.
okay. Okay. Thank you anyway. Gustavo, Patriota. Hola.
Jorge, I don't see Walter Gustavo here. Do you see? I don't see his name.
No, she texted me, he texted me, but I don't see now.
Yeah, I don't think it's connected. Yeah.
Yes, disconnected. So probably we can move to Ecuador. Manuel and Nelson are on the line. How is the approach in our critical care Hospital Espejo, a high public hospital, and after Nelson that works in a stroke center and the private one? ¿Cómo es la aproximación, Manuel, a esto, al paciente en coma en Ecuador? ¿Qué es lo que vos ves en el hospital público? Estás muteado, Manuel. Estás silenciado.
Disculpas.
Ok.
Good morning, everyone. Sorry, I will speak in Spanish. Okay.
Please do. Yeah.
Como ya dijeron antes, básicamente tenemos el mismo problema con la familia, y es que el poder transmitir que el paciente está en coma es motivo de dificultades y es motivo además de la evolución de la información en lo que resta de su evolución. Solo quiero notar un punto adicional, y es que es difícil, sobre todo dependiendo del tipo de hospital, porque incluso los hospitales son diferentes, los familiares son diferentes, el nivel cultural de nuestros pacientes son diferentes. En el caso de mi hospital, es un hospital público, el más grande del país, que manejamos una población con un nivel cultural y social que no es alto. En ese momento, el entendimiento del coma se vuelve más difícil. Y la verdad es que cuando incluso la información cambia de un médico tratante de un día a otro, hay problemas en que entiendan que está en coma. Entonces, la verdad, debemos encontrar una manera de que la población más vulnerable socialmente entienda qué representa que el paciente esté en coma.
Dame un minuto para traducir. So,
Ok.
Claude, what Manuel is saying that he's working in the main public hospital in Quito, from Ecuador, no? And thank you, Giselle. I know that you need to leave, and thank you for being here.
And
This
thank you all for
10 minutes.
connecting.
Thank you. Gracias. So, Claude, he's saying that he has the main problem, no? And how to approach the family, and that probably we will need something similar to happen in Brazil, no? I guess that Giselle was talking all Brazil and Casia too, no? Despite they are in different areas, San Pablo and Rio de Janeiro, important cities, no? Ok, Manuel, adelante.
Finalmente, hay un tema que es crucial, y es que la mayoría de los pacientes en coma al ingreso, sobre todo de trauma craneal, transmitimos el hecho de que como parte de su tratamiento reciben sedación, y muchos familiares creen que su estado se debe a la sedación, y eso se vuelve después un problema en poder sacarles de su imaginario que no es la sedación.
So also the problem is some confused situation, as was pointed out before, is about sedation, and sometimes we no hacemos lo que corresponde. Eso dijiste, Manuel.
Decía que es difícil que luego la familia entienda que no es la sedación la responsable del coma. Ellos asumen que es parte.
Sometimes it's very difficult to explain to the family that is not the sedation the cause of the coma, ¿no? Dale, seguí.
No más, gracias por lo pronto.
Ok. Nelson, ¿ya estás ahí? Porque no había podido acceder. Nos quedaba Gustavo.
Ya está Nelson ahí.
Nelson, dale, ¿qué tal? ¿Cómo andas?
Hola Walter, hola a todos.
Hola.
I'll switch to English. So yeah, in our third world countries, comparing to the US, it's a complete different reality because of absolutely everything. From the community standpoint, as Manuel was saying right now, there is absolutely no knowledge about what coma means. So they don't understand what is a coma state. Many people assume that the coma state always arrives because the doctors are sedating the patient, and many people is way more concerned about prognostication because having someone with neurologic disability at home means a complete change in all the dynamic of the family. There's no understanding of what coma means, who wakes up from coma, who doesn't wake up from coma, why coma exists. On the medical end, we are very restrained on what we can do, especially in public hospitals, but private happens almost the same, as we don't have access to EEGs. So patient can come because they're seizing, and then we don't know what is going on. And what happens many times is that because we don't have initial tools for workup and diagnosis, we end up doing much more than we should, as Manuel was saying, sedating the patient, putting the patient in a tube, putting the patient in the ICU. And in our ICUs, we live the same thing that you lived only in COVID, that it looked like the ICUs were getting full all the time, every single day. So that triage thing is difficult. And on top of that, we end up putting more people in the ICU because if we don't have the tools to assess what's going on, they end up tubed, they end up sedated. We don't know when to reduce sedation either. So in the physician spectrum, coma is difficult as well. In my country, especially, we don't have an intensive care fellowship. We don't have a neurology fellowship neither. So having a neurology assessing the patient in order to understand a little bit more, at least the coma neurologic exam, to take any further decisions on what we are going to do for the patient is almost null. We have a chat in the country for the public system where we help them a little bit about when they have questions on what else can we do. But you have non-neurologists in the majority of places on the country. So it's a big issue, and I always tell Panos and I always tell Chetan, for us in third world countries, the Curing Coma campaign has a much broader spectrum because there is a lot of patients that can potentially be reversed, that you already reverse it every day when they arrive to your emergency rooms, that they die here because of all the lack of tools that we have and of general knowledge.
Okay, entonces, so your opinion, approach, or comments, Gustavo Patriota, from more from the neurosurgeon side, that
Good
sometimes
morning for
are
all.
the same side, no?
The think of the neurosurgeon is simple. We think the patient have a pharmacologic and no pharmacologic coma. So the more the great patients have a traumatic brain injury and intracranial pressure, when they leave this phase of intracranial pressure, you know this about multimodality and monitoring, you could wake up these patients. And some patients have structural lesions and they not wake up. So this is common, and we have to treat them with pharmacological and external stimulus and wait. So this is a simple view of coma in a neurocritical care.
Okay, it's clear. So here, until now, we have the same sequence, no? The problem with how the family to understand that we are not well educated. Nelson had the presence of a neurologist, that is true, at least in Argentina and other countries in South America, is no family. The neurologists are more on the consultation of the outpatients, no involving the inpatient. So, and in the critical care is very, very strange, no? Okay, so we can move to Colombia. Luis Fermín, ¿estás ahí?
Sí, aquí estoy, Walter.
Bueno, y ahora le vamos a pedir ayuda, we will ask help also José Ignacio for doing more comments and a question. Dale, Luis, ¿cómo es la aproximación de ustedes? ¿Qué dificultades se encuentran?
Buenos días a todos. Los espero
En
el
inglés, ¿podés
28.
hacerlo en inglés o si no hay que traducir?
¿Me ayudas a traducir,
Dale.
Walter, por favor? Bienvenidos al próximo Congreso Neurocritical Care Suramérica Medellín. 28 a 30 de mayo son todos bienvenidos. Y arrancando con el problema de coma, hay tres factores importantes en la parte de la atención a estos pacientes. Uno, el nivel de la parte educativa sociocultural. Dos, la parte de la rapidez de la accesibilidad de los centros de emergencia y la sensibilización de la importancia de la reanimación y de la importancia que es enfocar bien el coma y sacar adelante estos pacientes. Y tres, falta de protocolos organizados en la parte de la reanimación y de la obtención de un mejor resultado de nuestros pacientes.
Entonces, pero no me quedó claro. ¿Podés volverlo a repetir si hay problema de comunicación entre médicos, enfermeras y familiares?
No, yo creo que los problemas son la información como sea de los pacientes a los médicos, falta de protocolos desde la parte de salud pública para la rapidez de obtención y una adecuada reanimación de los pacientes en coma y la construcción de adecuados protocolos en la parte de salud pública y en la parte de las ciudades, tanto para saber la importancia de la reanimación y buenos resultados de estos pacientes.
So, Claude, Luis Fermín from Medellín, Colombia, he started with the invitation to the next South American meeting in Medellín, May 28, 29. And after the publicity, he said that one of the main issues in Colombia is the lack of protocols for more related with how to resuscitate the patient and about the results. And also he said that lack of protocol in the public health, in this sector. José Ignacio, ¿estás por ahí? Hola, hola.
Aquí estoy, Walter. I'm here. Sorry.
Okay.
I'm
Avanti.
on call today, so I'm in and out of my office here, going back to the ICU. But I just want to echo what Luis Fermin said about the invitation to the South American chapter. Just remember in Medellín this year in May. ¿Se acuerdan de la invitación de la reunión de Neurocritical Care en mayo? And my question, and I'm going to say both in English and Spanish, so that, you know, for all of you, is if we can go, since we have people from pretty much almost every single, at least Portuguese and Spanish-speaking country in South America. I would like to hear from you what if there is any legislation or is any laws in your countries regarding withdrawal of life-sustaining treatments. You know, since we deal with this all the time, right? So we have this pessimistic approach to patients in coma, of course, that we're trying to change because we do believe that these patients deserve a chance and they get better. I wanted to know from you if a family comes to you or if the other physicians or the nurses are asking you to withdraw life-sustaining treatments, how would you deal with that? Not only from in your hospital, but also from the medical legal standpoint in your country. Voy a repetir esto en español para todos. Entonces, la pregunta que quería, como están todos aquí, hay representantes de casi todos los países de habla hispana y de Brasil, y de portugués. Me gustaría que comentaran sobre la disminución o el retiro del manejo agresivo de estos pacientes. Como siempre tenemos esta visión pesimista, ¿no? Obviamente los médicos y las enfermeras también somos culpables, ¿no? También tenemos esta visión negativa. Tenemos neurofobia, ¿no? En general. ¿Cómo manejarían ustedes desde el punto de vista de protocolos que tengan en su hospital y desde el punto de vista legal en sus países? ¿Cómo sería el manejo de estos pacientes si la familia o los otros médicos o las enfermeras le están pidiendo a ustedes o creen que no hay esperanza y que quieren reducir el manejo agresivo?
Yo le preguntaría primero a Corina, que está en el avión, está por salir, que nos cuente brevemente su opinión. So, Corina, your approach to this issue. Corina, está silenciada. Cori, está silenciada. Hola, Corina, estás. You are
Reactivar
mute.
audios.
Ahora,
A
ahora
ver,
sí.
ahora.
Ok,
Hola, buenos
ahora sí.
días a todos. En realidad, no voy a poder hablar porque acá hay mucho ruido.
Bueno.
La importancia del coma es muy, muy, muy importante, pero en este momento alrededor mío hay mucho movimiento. Prefiero escuchar, perdóname,
No, está
Walter,
bien,
prefiero
perfecto.
escuchar porque es una locura esto.
Thank you in any
El
way, okay?
silencio.
It's a lot of
Saludos a
movement
todos y encantada de verlos.
and it's a sound, it's noisy, and so she preferred to just to hear. So, Pedro Grille,
Hello.
¿cuál es tu aproximación? Which
Hello,
is your
everybody.
approach?
Hello. Hello, Walter. Well, my country is a little country, but we have more or less the same problems that is discussing here. The first is what coma is, the diagnosis of coma. In my country, there is no consensus or protocol. The other is nihilism, the self-fulfilling prophecy, prophecy that is a consequence of this. And the other is we have no data, national data about long-term prognosis. For example, I'm now writing a study that is the first study in our country. We could continue the evolution and the rehabilitation of the patient to 12 months. And we have seen that the the improvement, functional and cognitive improvement is evident. And more than 70% of people with moderate or severe traumatic coma, traumatic brain injury improve during the rehabilitation. The rehabilitation is another problem we have in our country in public hospital. So there are so the problems we have, and we share. I think we share the problems with the rest of Latin America. That's it. Thank you.
Okay, so similar problems, similar, or I don't know, the same cause, but similar problem.
Yes.
Okay, we can move to Peru. Omar Heredia from Peru. What is your approach, difference with other, or similitude with other countries? Omar, ¿me escuchas? Hi, Omar.
Está silenciado, Omar.
Thank you.
Ahora sí, buenos días con todos. Hi everyone.
Hi.
¿Me escuchan, Walter?
Sí, sí. Ahora sí.
Bueno, sí, buenos días con todos. ¿Me ayudas con la traducción, por favor?
Dale.
Bueno, nuestra realidad es similar a la de otros países, a la de Ecuador. Acá en Perú hay muy pocas unidades de cuidados intensivos especializadas en pacientes neurocríticos. Apenas tenemos 4 o 5 unidades para todo el Perú y la mayoría de ellas son de pacientes posoperados, de pacientes neuroquirúrgicos.
No, para. So Omar is pointing out that in Peru they have very few units and devoted to neuro, and mainly almost of them are for neurocritic from post-op neurosurgical or post-neurosurgical procedures, ¿no? Go ahead, dale, Omar.
La prevalencia de pacientes en coma en las unidades de cuidados intensivos es aproximadamente el 25% acá en Perú. Y de ellos, de este 25%, el 50% de los comas son de origen traumático.
Bien. So they say 25% more or less in the ICU are neurocritical care patients, and almost of them are because TBI, ¿no? Por trauma de cráneo, dale.
Yes. La evolución de ellos va a depender de muchas condiciones, sobre todo de la condición socioeconómica. Hay una limitación muy importante para lo que es la neurorehabilitación, una vez que los pacientes salen de cuidados intensivos. Y eso muchas veces, la parte final del tratamiento, es la que marca la diferencia entre un buen y un mal pronóstico neurológico de estos pacientes.
¿Puedo repetirlo otra vez, esto último?
Excuse me? ¿No?
Si puedes repetirlo otra vez.
Eh,
Pero,
Hay una gran falta de neurorehabilitación, ¿no es cierto? Una vez que el paciente sale de cuidados intensivos, la ausencia de una adecuada neurorehabilitación es la que marca la diferencia entre tener un buen o un mal pronóstico neurológico. Muchos pacientes logran salir de cuidados intensivos e incluso del hospital, pero debido a la falta de neurorehabilitación fallecen en casa. Tenemos una mortalidad oculta de estos pacientes muy grandes.
So Omar is pointing out that the lack of rehabilitation in Peru, I guess for the public hospital, no the social insurance, is a big problem, and the people also is the main fact, one of the main factors for prognosis. No, I add also that what we learned from the best trip, that the main problem is not the ICU, it's the pre-hospital. Sometimes in some countries, less than 50% of the patients arrive in ambulance and take 2 or 3 hours. And after the ICU, more than ICU. And after, when the patients are discharged, also in the hospital or in the community, the lack of rehabilitation is a big problem. Okay, so Carla, ¿estás ahí? Nos falta completar. Hola. Carla, no te veo. Hola.
Walter, tenés que admitir a Carla, a Sergio, a
Sí,
Olivier.
no, están admitidos como panelistas, pero eso lo hace Connor. Ya les pedí que lo admitan a pesar de Carla. Bueno, nos movemos entonces. We can move to Chile. Andrés Recio, you remember that we read a nice paper that was published the last year, and we have a lot of data from Chile, no? Andrés, go ahead.
Yes, thank you for your inviting me. We can speak about the Chilean data or about the LATAM data. What do you prefer?
What do you prefer? Speak a little bit on Chile and after Latin America. Right?
About Chile, we have a coma prevalence in the ICUs about 8%. So 8% of patients at the ICUs have coma, according to the Come Together study. More or less, half of the patients had cardiovascular-related etiologies, so stroke, acute ischemic stroke, ICH, subarachnoid hemorrhages, and cardiac arrest. More or less 1/3 of the patients had traumatic brain injury, and the other third of the patients, more or less, had other etiologies, so meningoencephalitis, status epilepticus, brain tumors. We have a big diversity because, you know, our country is so long with big differences and big health differences to get the opportunities to have neurosurgeons, ICU. We have only 2 neuro ICUs, so there's a big differences to get access to good neuro ICU care. And as you told, as everyone told, the people, but also the healthcare workers don't have a good knowledge about coma. And as you have already told, there is the self-fulfilling prophecy is a big problem here in Chile as in Latin America. And it's very important that all the health chain should be provided from the pre-hospital, ER, ICU, and very important to keep that in the rehabilitation, because if you don't have a good rehabilitation, to have a good ICU care, tracheostomy, gastrostomy, and then to the regular ward to have a pulmonary embolism, and then to don't have a good prognosis is only money loss. So for us, it was very important to have that good study in order to show where we need to put the resources. So at least in Chile, we know where there are the gaps to go to the administrators to say to them, okay, we need to have a neurosurgeon in the northern part of the country to have a better rehab system. In the southern part of the country, we need to implement, I don't know, PBTO2 in other parts because we have ICP monitoring. So it was very important to make that study.
So Andres, but you have the last 10 or 15 years a law that if some patient, particular trauma or TBI, arrive to a hospital and they don't have ICP monitor, this patient is transferred to the private facility, and after the government pay for this patient. It is working in the real day by day, or it's just the law, just letter?
Yes, we have
also the opinion from Danilo Fischer after. Andres.
Yes, there is a unified intensive care system. So if a patient goes to an emergency room and he needs a critical care bed, in that hospital, there is no critical care bed, he will get a critical care bed. The problem is that the delay to get that bed sometimes is too long. So, for example, 3 days ago, a patient with a mild TBI GCS of 13 come to our hospital, but 24 hours later, and that GCS of 13 finally ended with a brain death. So for the politicians and for the administrators, it was a success because the system worked, but the patient finally died. So this unified system of worked, but it is so slow that in the reality, it needs a lot of improvement in order that it really works. Danilo?
Danilo?
Hi, good morning.
He's unhappy after the soccer game of yesterday night. Sorry, Danilo.
I am
We
Colombian
won.
now. Nowadays, I am like Jose. Well, good morning for everybody. I think formerly I was Peñarol fan. I think that as Andres said, here in Chile, the first is that is an uniform of definition of coma. Yeah, Glasgow less than 9, but not all our colleagues know this definition. Yeah, and not everybody knows about the physiopathology of all the kinds of coma. Yeah, so the treatment of those patients are very different. Yeah, so not all the hospital has EEG or MRI. Yeah. And another issue is that unfortunately here in Chile, the access to the best technology to the monitorization of those patients, for instance, ICP or PBRO2, not the centers have it. Yeah. So here in Chile, in our country, the access to the technology and so the treatment for the most severe neurological condition is very asymmetric. So Andres and me, we work in I think that the best centers here in Chile, but the reality in the other part of the country and in our city, Santiago, is very different, the reality. That is that situation here in Chile.
So you have another issue. Many of the speakers speak about the lack of protocols, lack of education in community doctors and nurses, and you have lack of technology. What is more important, education, technology, or both?
Is for me the question?
Sí, para vos.
Yeah, I think that, in my opinion, the first step is to teach the people about what is coma and operational definition in what is coma. Yeah, the role of physiopathology to explain it, and what are the minimum elements to make a correct diagnosis. Yeah, because not all in our country, not all centers or in our country has the technologies, yeah, the best technologies. But I think that with a few treatment, we can get better results.
Education first. So
Yeah.
we're looking. Thank you, Carla, for being here. Is another opinion that we need from Brazil, from the south of Brazil, Porto Alegre. They are called gauchos. I don't know, because they are similar to Uruguayos and Argentino. I don't know. Okay, Carla, what is your opinion? You heard all the discussion.
Hello, everyone. And it's a great pleasure to be here participating on it. With my opinion, I will say that Southern Brazil can be a bit different from the rest of Brazil. And Brazil, as a big country, we have like developing countries, developing cities here inside. So in a big center, in a developing city, I think Coma has a great treatment with all specialists and all the exams, as Danilo told us, right? RM, and they will investigate it. It's okay. But I think most of our country, they don't have access, even in emergency department. So I think there is a great problem about the epidemiology of the local, the city, which is the most important cause of coma in our city, for example. We have to study it and then develop protocols, local protocols, to study the most frequent cause of coma, depending on each side of the country. So, in undeveloping cities, for sure, we have a great problem of many cases of severe patients that they come to the emergency room and then, oh, they only have access to a tomography, maybe not. They do not investigate this patient and they die. Oh yeah, they say to the family, oh, it was so severe. We do not have access to that. So as medical part of this system, I think it's not only problem of the politicians. We also have to support them to organize local protocols. I think this is a big challenge, but we have to do that.
Okay, thank you. So we need to move to Venezuela. Jacobo Moro. Jacobo, tu opinión? Jacobo is from one of the city of Venezuela from on the Caribbean side, ¿no? Barcelona. No España. No
Pero
Spain.
primero, date las gracias, Carl Huarte,
Habla
por
en
la
inglés.
invitación. Date las
Dale.
gracias, Huarte, por la invitación y a la vez reconocer ese trabajo de Ignacio Henfield desde la Sociedad de Neurocritical Care por el Coma. Nosotros no teníamos esa cultura de la difusión. Desde el año pasado estamos, como que nos incorporamos, estamos difundiendo eso desde la Sociedad de Medicina Crítica a la comunidad médica. Y realmente este año hemos hecho también una buena propaganda, una buena difusión. En Venezuela, dos problemas.
Para, Jacobo, para traducir. ¿Y qué es exactamente lo que hicieron en la sociedad? ¿Publicitar lo del Coma?
Fundamentalmente difundía a través de nuestros medios de difusión. Hicimos un pequeño video que enviamos a Coma desde la unidad de terapia intensiva del hospital y lo hemos difundido.
Okay. So Claude and José Ignacio, he's saying thank you, and also he was involved and related with the NCS and particularly with Coma Cure campaign, and they did some videos and upload, I guess. So Jacobo,
entonces fíjate, dos cosas. Uno, desde la comunidad, es decir, la gente con el paciente en coma, sobre todo en el tiempo, las expectativas caen inmediatamente. Es decir, la gente tiene la concepción de que el paciente, cuando hay la pérdida del conocimiento que dura muchas horas, las posibilidades de sobrevida son pocas.
La pregunta, so Jacobo is saying that when the coma is longer, the expectations are lower. No, it's similar that Claude, that you discuss in the Asian chapter, no? That when you run 1 day, 2 days, 3 days, 4 days, 5 days, and continue in coma, all the people start to say something like, let go, no? Something like that.
Y lo otro, Duarte, desde la expectativa de salud es que el paciente llegue a las emergencias y realmente la gente tiene cree que desde la terapia intensiva podemos recuperar a todos los pacientes con coma. Y realmente hacemos un gran esfuerzo, pero el volumen de camas que tenemos en Venezuela está muy reducido.
So he's saying that sometimes the people believe, the population in Venezuela believe that ICU can solve all the problems, but sometimes, or almost the time, they don't have enough ICU beds. So the expectation no satisfied, no? Okay.
Entonces, fíjate, bueno, es importante que las medidas de primer nivel en los hospitales se hacen. Es decir, llega el paciente, se le hace toda la medida de soporte, entre ellas la intubación, pero el problema es cómo le garantizamos la ventilación luego que los intubamos.
Claro. Just so you can add and use the first line of support, but we cannot guarantee the mechanical ventilation, for example. Okay.
Que
lo último, dale.
Buena. Intentamos de temprano hacer la identificación si es un coma estructural o un coma metabólico. Yo creo que eso hemos avanzado bastante en Venezuela.
So he's saying that he thinks that they move forward with recognize if the coma, the etiology of coma is a structural one, TBI, stroke, whatever, or is a metabolic one. Okay, gracias, Jacobo. We need to move to Paraguay, Bolivia. ¿Está Jorge Flecha? Adrián Ávila.
¿Qué tal?
Jorge, dale, arranca.
Buen día, ¿cómo están todos?
Después Adrián. Bueno, Jorge,
cortito.
I want to introduce Jorge Flecha is the ICU director from Hospital Trauma in Paraguay, in Asunción, the capital, and is the biggest hospital for neuro patients, in particular for trauma patients. Go ahead, Jorge.
Sí, sí. Yo estoy en un hospital del trauma, como dijo Walter, un hospital único que recibe a todos los pacientes politraumatizados. Vemos trauma de cráneo a diestra y siniestra ahí. En la proximidad de la edad, más o menos entre 17 a 25 años aproximadamente son los pacientes, la mayoría, el 80%. El 70%, 75% son accidentes de moto sin casco. Más del 50% viene del interior a más de 100 kilómetros de la capital.
Para un minuto.
Sí.
All the most important or the more complex trauma patients arrive to this hospital, almost male, almost vehicular accidents, and part of the patients arrive from the inside of the country, more than 100 kilometers for transfer. Dale.
Y lo que nosotros vemos es la atención prehospitalaria, el traslado del paciente desde el interior del país, pues no es en las mejores condiciones. No sabemos cómo viene trasladado. Por eso es que muchas veces los pacientes en coma no sabemos cómo van a evolucionar. No sabemos si realmente fue el coma por el trauma de cráneo o fue porque el 70% de los pacientes son politraumatizados. Tienen trauma de tórax, trauma de abdomen asociado a un trauma de cráneo.
For them, it's difficult to differentiate if the coma is structural or because the TBI, or in particular, is very difficult in polytrauma patients, because the ventilation, also because the conditions of the hospital are not so good. Okay.
Sí, y lo cortito nomás, lo que yo creo que lo que faltaría más educación, inclusive no generalmente en los pacientes, sino en los médicos mismos, ¿verdad? Porque todo coma, la mayoría nos basamos en el lasgo, o sea, la gente hace por el lasgo como diagnóstico de coma y no tenemos un protocolo de manejo de los pacientes en coma. Tampoco el paciente que sale de esa situación, no tenemos un seguimiento post alta de terapia intensiva. Y la mayoría de los comas, en un 70, 75, 80% son secuelares. O sea, van a sala y ya no sabemos cómo siguen. No sabemos nada de eso. Entonces yo creo que falta educación, personal médico y protocolos de manejo, lo que nosotros no tenemos.
He's pointing out that one of the main issues is lack of the education, more in doctors than in the community, and absence, lack of protocols. And also many of the coma patients, when they leave the ICU and go to the floor, they have many sequels. So you are pointing out, lo que estás diciendo un poco que el pronóstico neurológico, que es difícil, se empieza a jugar antes de llegar a la terapia, ¿no?
Así mismo, así mismo.
Okay, so the neuroprostecation is very difficult. So we start to play this game in this, or the patient start to lose opportunity in the pre-hospital, because the time, the distance, and whatever. Bolivia, Adrián Ávila.
Hi, everybody. Thank you for your kind invitation, Walter. Well, in Bolivia, I think we have the same problem as in Latin America, but in Bolivia, we have many cultures. Two of them are, for example, Aymara and Quechua. And if someone is in coma, they believe that they are going to recover or wake up. And so some of them decide to request discharge from the hospital. Even though they have a public insurance, they prefer to ask discharge. This is our big problem in Bolivia. Another, we live in high altitude. In fact, I work in a hospital more than 4,000 above sea level. That's another problem. And as you said, in Bolivia, we lack in personal and human and economic resources, and many of you and we are trying to change that reality. And in one Congress in Bolivia, we said to Walter, before and after Walter in Bolivia, we have a different approach to manage TBI. Thank you again, Walter, for all your support. And thank you for your kind invitation. Thank you.
Okay. Sorry.
Walter, can I show the data from Latin America?
Para, a ver. ¿Quién quiere compartir? ¿Quién quería compartir los datos?
Andrés.
Ah, Andrés, para que se lo tenemos que pedir a Connor, si te habilita la pantalla.
No, just talking about that.
Ok, talking,
Yes.
dale.
Yes, because
Dale.
last year, May last year, we made the Latam.
Escúchame, dame 3 minutos, Andrés, 3 minutos,
problem.
porque si no, ningún argentino va a hablar y no puedo volver a mi país. Dale. Dale. Avanti, avanti. Go ahead.
Bien. ¿Yo?
Sí, vos, dale, dale.
Sorry. So last year we made the Coma Latam study. Maybe a lot of you worked with us. So first of all, thank you. We had data from 19 countries from Mexico to the south. We only don't have data from Nicaragua, but from all 19 countries. We have data from more or less 400 different units across all Latin America, as I told you. We have data from 8,000 ICU patients, a little bit more. And from those patients, 1,300 patients were in coma according to the Come Together study. So that's more or less 14% of the patients. So 1 in every 7 patients at the Latin American ICUs were in coma. So that's a lot. So 1 in every patient in the Latin American ICUs are in coma. That's the double prevalence of coma that we had in Chile. 1 in 7 patients, 14%. According to the etiologies, 25% of those patients had traumatic brain injury. Half of the patients had cardiovascular related coma, so acute ischemic stroke, subarachnoid hemorrhage, intracerebral hemorrhage, and cardiac arrest. And of that, more or less 1/3 ICH, a little bit more subarachnoid hemorrhage, and a little bit less acute ischemic stroke. And the other half, part of the patients were status epilepticus, encephalitis, and metabolic coma.
Okay.
The median age was more or less 55 years, and the median days of duration of the coma was 6 days at that time point. And for example, the withdrawal of life sustaining support was already done in 20% of the patients. For example, so in those median age patients, at day 6, 1 in 5 patients were already withdrawing the life sustaining support. So as we have already talked about the self-fulfilling prophecy that was already done.
Okay.
We have
to change, Andres. We need to change because we have close to the end 6 minutes.
No, we have
one more data. Un solo
yes,
dato más.
One more data. We have the 2 weeks data only for half of those patients, and the lethality for those patients is 30%. And of those patients who died, 60% died with life-sustaining support withdrawal. So again, the self-fulfilling prophecy probably. So it's very important to educate, not so to educate the doctors and nurses and the people who work with these patients, because maybe we are doing too much life-sustaining support withdrawal, because I think that we are doing too much life-sustaining support withdrawal, because they seek to have too much withdrawal life-sustaining support therapies.
Okay,
So,
thank you.
mhm,
So
very-
I remember, no, we need to move to Argentina, sorry.
Please.
Dale, ¿qué quiere decir?
No, just we're going to
esto es todo.
participate in the next few months.
Dale, déjame redondear con Argentina, después, after the Argentina opinions, we have two people. I will ask to Claude and Jose Ignacio to do a brief summary, pointing out the most key, the important points, or the key points. Brenda, estás muteada, Brenda. Brenda, estás muteada. Brenda, estás en mute, estás muteada, no te escuchamos. Brenda, no te escuchamos. No. Pero, Brenda, pará. No te escuchamos,
Ahora sí,
Brenda.
sí, ya
Ahora,
está.
recién ahora, hablaste al cohete, al pedo. Dale.
Pero
Dale.
los 6 minutos.
No,
Hola.
tenés 2. Tenés 3 minutos, pues yo tengo que cerrar y está Francisco también. Dale.
Bueno, saludos a
Rápido.
todos y gracias, Walter, por la invitación.
Dale, va.
Realmente el coma, ¿cómo lo abordamos en nuestro hospital? Hemos creado un protocolo. De inicio teníamos dificultades con la familia al ingreso del paciente, el manejo en la guardia, el tratamiento, en la terapia intensiva con esos problemas que llegaban los pacientes, al margen del tratamiento, del diagnóstico. El problema era cómo abordar con la familia. Hemos
Entonces,
creado...
espera. One of the problems that we, with this, particularly with Coma Cure campaign that was involved, and after with the Compose study, we create some protocols. I can say we because I am the same hospital. And Brenda particularly create a good network of communication. He spent many times during several weeks, also with Francisco that is here, very noble doctor, speaking to all the people, the administrative people, the nurses, and people that works in the 24 hours for work, make that the hospital works, and people from security. So it helps a lot for identify and move forward and fast with the patient. Anda, adelante, dale.
Bueno, y de esta manera hemos logrado que el enojo de la familia o la mejor comprensión de la familia frente a esta patología sea más llevadera, independientemente del pronóstico. Los pacientes pueden entrar a un protocolo de Glasgow bajo o seguir adelante con la intención de tratamiento, intensidad, y esto lo hacemos de acuerdo al neuromonitoreo que tenemos.
So what she's pointing out that this protocol helps to doctors and nurses, but particular more the family to go through this process and to be sit outside the ICU during many days and sometimes more than a week or 10 days. No, it's Brenda, ¿qué más?
Y porque muchos de nuestros pacientes con trauma de cráneo grave evolucionan a muerte cerebral y estos pacientes detectados precozmente pueden salvar más vidas en otras situaciones.
And also, she believes that we have all the monitors, almost, and it helps that to move forward and faster for when we can say, okay, this patient is for donation for and not more for, so we switch the treatment, different treatment, and it helps also to other life. And we are very good training because we are part of one of the center of reference for donation, and we are well trained, in particular Brenda, Francisco, and other residents in communication. I guess that is a good point for us. Where in the hour? So, Francisco, 2 palabras. Francisco, estás muteado. Ahí.
Thank
2
you so much.
palabras.
So can I talk about the survey that we performed with Raymond and Dr.
2 minutos. 2 minutos.
So the last year we performed for almost 4 months an international survey around Latin American with Dr. Emanshu Prahadgar and Raymond Helbok. Was about how we can approach a patient in coma to evaluate the epidemiology, and the treatment, the general treatment. And the result was very different between the last survey that was performed in India by the Emanshu. So we achieved 147 participants. The most majority of the participants was from Mexico, Argentina, Venezuela, Colombia, and another country from Latin America. 60 country, so in total it was 60 countries belonging from LATAM. Sorry, I have some results here in this paper. It was a lot of results on the survey, but so we perform another question between the last survey performed by Emanshu. So we have results totally different, and have like has a novel point. Only 34% of the ICU, they use a clinical protocol to approach a patient with the diagnosis of coma. So that's mean that nowadays don't exist, or in Latin American, we don't perform a clinical algorithm to perform to approach the patient under the diagnosis of coma. And we use as a reference the protocol of neurocritical care. That was the version 5.0. And what else? So only less of 4% of the countries that they participate in this survey, they use also a protocol to approach a patient with the diagnosis of brain death. So also the same problem with coma happens with brain death. So about the protocol.
Podemos cortar ahí.
Yeah.
Ahí está.
So
Dale.
yeah, in overall we find a lot of so we have a lot of results totally different within the last survey, but yeah, that is the study that I carry out with Walter, and maybe we will publish very soon in the journal of the society.
Okay, thank you, Francisco. So I guess that probably we need to recognize that we have many papers about LMIC, starting in one of the nice papers for me at least was one that Giselle was the first author about the gaps, particularly in stroke in South America. Very nice paper with analysis. Also are some papers from Himanshu, Manuel that was part of the best trip trial, and other people. So probably we need more data from us. Last question, neuropronostication for each of you. Is easy or no at the beginning, no? And education for everybody. Kasia, neuropronostication, easy or no?
Sorry about the question is about if you do perform
neuropronostication at the beginning when we admit the patients, first
Wants to
hour,
know
first
if it's
day?
easy or not,
Easy or
Katia.
no? Monitors
It's an easy
helps or no?
question.
Okay. No, so we do use neuromonitoring in our patients all the time, but it's very hard to do a neuroprognostication in the first few days that the patient comes to the ICU. So we have to really take a little bit more time.
Okay. Giselle, that you are in one of the top,
Yes.
Einstein, no? You have all the toys. I don't know in the public hospital, but
Yeah. Well, I am at two hospitals. I'm also at a public hospital at Unifesp. So I agree with Cassia. And it's actually, this is the topic of in our R1 grant that we have with David Greer called SPARE, where we are comparing the way we neuroprognosticate in Brazil with the US to evaluate how often withdrawal of life support, can have an influence upon the prognosis in patients after cardiac arrest. So I think it's a huge gap. It's different, but I agree with Cassia that overall we have to wait, not do it too early.
okay. Carla, you work in the public hospital, but you have all the toys.
Not exactly all the toys,
No, but almost.
but in a public system, we still have a lot of challenge, especially still investigating it better and also in rehabilitation of those coma patients.
Okay, Gustavo, when we ask you, the neurosurgeon, come with us and evaluate this patient, and you say, but the CCS is 3, 4, the pupils are, and the CT scan is a lot of damage. So neuroprognostication with this, the clinical and imaging, is easy to do, not to do? What is your opinion or recommendation?
Yes, I do. But neurophysiology is very dynamic, and neuromonitorization is for that. If you don't have the toys, you want to have them. So talk with the family, it's important. Examination the patient all days is very important to do neuroprognostication. So it past 10 days, the patient it's in coma. So you are wrong or you are right. So that's the way I do.
Okay, Nelson, move to Ecuador. Nelson and Manuel, go ahead, Nelson.
So for neuroprognostication, I think I will switch for the short term and the long term. For the short term, it's almost impossible without tools, without any sort of technology. It's very difficult. For the long run, it's really simple. We almost don't have neurorehabilitation in the country. So they are all gonna do very poorly after they are move out from the ICU. Regardless of how well that ICU was able to treat the patient, as soon as the patient hits the general ward and afterwards they go back to their houses and they have no rehabilitation whatsoever, all of them do very poorly. So it's different, and I disagree with the world that the self-fulfilling prophecy. I think that in order to call it self-fulfilling prophecy, we need to have two things. We have to have the knowledge and the tools to do everything and decide to stop doing things. We don't have the knowledge, neither we don't have the tools. So it's just the reality that our countries have. We are in a complete different situation that the first world countries are. So it's different. It's not self-fulfilling prophecy. We don't have many ways to act.
I agree with you, but remember that part of the confusion started when one of the first papers, probably Claude and Jose Ignacio remember, that talk about self-prophecy, but it was about to use or not to use mechanical ventilation in stroke patients. It wasn't amazing. So they say, if you say the prognosis is bad, and you in patient with GCS less than 8, and you intubate or no intubate and no mechanical ventilation, he will die. So it is because it was in this paper, practically was no ICP, no other monitoring than the general monitoring, no? So meaning mean arterial pressure, cardiac rhythm, and blah. Manuel.
Un minuto, Walter, para
Sí.
contestar la pregunta que hizo José Ignacio al comienzo. Y es que creo que uno de los temas a considerar es el manejo agresivo del paciente en coma. Probablemente creo que somos muy agresivos y con el tiempo hemos ido nosotros reduciendo esa agresividad. Por ejemplo, el mito de creer que la sedación es parte fundamental del manejo en coma. Eso no es así.
Ajá.
Cada vez la retiramos más precozmente. Creería yo.
Un minuto. Regarding to the question of José Ignacio, he think that probably we are in the past very aggressive with the patients in coma, and now we are moving to another direction. For example, start to withdraw the sedation earlier, ¿no? Dale.
Ok. Luego, el neuropronóstico en realidad es, creo yo, un gran problema. Y es que en la salud pública básicamente se lo hace de manera clínica. Y en un porcentaje importante nos equivocamos en cuanto al pronóstico.
Entonces, he said that in the public area, almost the neuroprognostication is based on clinical and sometimes CT scan, no? But he admits that probably we are doing many mistakes, no? In the early prognostication. Dale, Manuel.
Finalmente, una palabra de la ventilación mecánica. ¿Está bien, Walter? Una palabra de la ventilación mecánica. Bien. Ya. De las grandes series, sobre todo de las de Andrés Esteban, en lo que es ventilación mecánica, quedó claramente demostrado que la ventilación mecánica no aumenta la mortalidad en el paciente con stroke isquémico, es igual que el resto de los neurocríticos. Solamente en el hemorrágico es que puede tener alguna influencia en la mortalidad. Por tanto, también es un mito esto de la ventilación mecánica y el stroke.
So he said that because he was part of the team with Andrés Esteban, one of the largest series all over the world about mechanical ventilation. So in the subset of patients with ischemic stroke, mechanical ventilation is not related with the pronostication. Probably in the hemorrhagic stroke, but not in the ischemic stroke. Ok, gracias. Y ahora, Adrián, neuropronostication temprana, neuropronóstico temprano, ¿fácil o no? Dale.
Yeah,
Rápido.
I think so. In Bolivia, will depend on many things. For example, human resources, economic resources, and as you say, some of them after discharge, maybe the sequel won't kill them. Other complication like pneumonia, one other thing will complicate a patient. We think it depends on many other factors.
Sí, but you are talking more about the later pronostication, but at the beginning, neuropronostication is more
Of
clinical
course,
on
we
CT.
still using a clinical and the use
And
of CT scan.
Imagines, yes. Okay.
That's the both tools that we still using in Bolivia.
Okay. Jorge Flecha, ¿está por ahí? Paraguay. Dale.
El neuropronóstico para nosotros es bastante complicado porque solamente tenemos imágenes como medio diagnóstico en un hospital público muy pobre como tenemos. Y varias veces sí.
For them, Paraguay it's a challenge, it's very complex, it's a problem, no? Because they have clinical approach and the CT scan. Dale.
Sí, es bastante complicado. Solamente hacemos la parte, una vez suspendida la sedación. Yo hablo de los hospitales donde tenemos trauma de cráneo, es lo más importante. Sobre todo, incluso, tengo anécdotas más, sobre todo un paciente con lesión nacional traumática, que la imagen era bastante fea, por resonancia inclusive, que por suerte tenemos ahí, pero es tercerizado. Y la clínica del paciente no daba con lo que es la resonancia, que es lo que describen muchos estudios. Entonces, es muy complicado porque le habla a la familia que no se va a despertar probablemente por la imagen y después al final pasa otra cosa. Muy complicado para nosotros, sí.
So el problema es la comunicación. So he said that sometimes use the clinical, the CT scanner and after MRI, but different approach and sometimes confusing, and we as doctor we don't know exactly what to communicate. Gracias.
Dale.
Jacobo, Venezuela. Despacio así, dale. Este
Mira,
último
Walter,
minuto.
nosotros tenemos una cosa favorable en Venezuela que es la parte de la imagen. Hay tomógrafos en casi todos los estados, en casi todas las provincias.
So they have Venezuela, they have a positive situation. They have a lot of CT scanner all over the country. Dale.
Entonces, la parte de diagnóstico temprano es es muy importante.
Pero
Yo creo que
diagnóstico y neuropronóstico temprano.
ahora, neuropronóstico, tenemos problemas por las limitaciones que tenemos. Bueno, tú tuviste la emergencia de los hospitales de Venezuela, que en una etapa buena, ¿no? La etapa que tú viniste. Pero ahí tenemos problemas y en terapia indudablemente hay mejores perspectivas. Hay mejores perspectivas y uno se da cuenta, sobre todo ese paciente que uno sigue, sobre todo lo aprendimos en entrevista, el trauma de cráneo en los 3 6 meses, cómo la gente de verdad trataba de cuidar a sus familiares.
Okay, so he said that sometimes when, like in this time, like are bad times, they have a lot of patients that cannot be admitted in the ICU, so they are in ED. It's like orphan patients, so they have less hope to do better, ¿no? ¿Quién me queda para ir terminando? Pedro, neuropronóstico, fácil o no?
Well, no, it's a difficult matter. Data from Uruguay, the paper that I'm writing, we continue to the evolution to the patient to 12 months. This is the first work study in Uruguay about this. We measure the disability rating scale, and we see that there is a functional and cognitive improvement, and the patient have no or minimal partial disability in 50% of the patients. So the patient continue to
improve. Or
yes,
sometimes die.
There is a window of opportunity
Okay.
to see, and that is very important.
Okay, so continue with the research. This research is very important. There are very few papers also in Norway, I guess is the first, and also very few papers that continue to follow up beyond 6 months, 12 months, and few papers that arise 18 months. But
yes,
everything, a lot of patients improve, but part of the patient die and part.
And in this study, we measure biomarkers, blood biomarkers. We have information about it. This is very intense. Thank you, Walter.
You need to talk with Sergio Aguilera about biomarkers.
Yes.
Luis Fermín en Colombia. Y así vamos terminando.
Three important parts. First, I believe we cannot forget the focus of the semiology in the coma patient. Two, we must will resuscitation and then rehabilitation protocols. Third, bad education, physicians, and then patients. In the prognostics in Colombia, there are many questions and answers. Too much research. I believe it must be individualized patients.
Gracias. Omar, faltas vos, ¿no? Perú.
Aquí. El pronóstico es difícil, como en todos los países de Latinoamérica. No siempre es el que encontramos en la literatura médica, en los estudios, porque no contamos con todas las herramientas para poder desarrollar todos los protocolos que están con nivel de evidencia. Por ejemplo, en hemorragia subaracnoidea, normalmente tú tienes que los WFNS 1 2 deberían ir bien, siempre y cuando se clipen tempranamente o se embolicen tempranamente. A veces hay muchos hospitales públicos que no tienen la capacidad resolutiva. Estos pacientes resangran y van mal.
Para, despacito, despacito. So there's some patients are with limitation, like in our countries, in South America and part of Latin America, and in Peru, people that suffer cerebral hemorrhage arrive to the public hospital. They are not going to calls. They are not going under surgery sooner. So because you need to get this one, get the OR available. Okay, dale, amor.
Para nosotros la patología con mejor pronóstico de todas las injurias cerebrales es el TBI, de lejos.
So for them, the different subset of patients, TBI is the patient that have better prognosis. For the others, they need other things that probably in public hospital they are not. Okay.
Sin embargo, para finalizar, una palabra, la falta de neurorehabilitación oportuna es la que termina marcando entre un buen y un mal resultado, ¿no?
I think that the lack of neurorehabilitation make the difference between the good results and good outcomes and not. Finalmente, Brenda, un minuto, Francisco, un minuto. Ahora te doy, Andrés. Neuropronóstico,
Otra
¿fácil
vez.
o no? ¿Eh?
Estoy muteada.
No, te escucho.
Ah, ¿me escuchas? Ah,
Sí.
perdón. Bueno,
¿Fácil o no el
afortunadamente,
neuropronóstico?
es complicado, pero tenemos herramientas.
¿Fácil o no?
No
¿Es
es
complicado?
sencillo.
Sí. Bueno,
No
dale,
es
dale.
fácil. No es fácil,
¿viste?
pero tenemos herramientas con las que podemos contar. Después del tomógrafo, las mediciones de la vaina del nervio óptico, Doppler transcranial, el pupilómetro, el brain for care, y en algunos traumas que siempre hacemos fallo. Es cierto que la rehabilitación es donde complica el pronóstico del paciente. Un minuto.
Dale. Muteado. Andrés, ¿querés decir vos lo que querías decir?
Yes. Sorry about prognosis in the acute phase. The only thing I know is that I know nothing. So we very exceptionally make prognosis in the acute phase. What we normally do is treat the patients very aggressively, doing what the onco-intensivists do. This ICU trial, a very aggressive ICU trial, poner toda la carne a la parrilla, so all the meat to the grill, treat the patient at the acute phase. Of course, if the patients during that acute phase show signs of bad prognosis, we stop the ICU trial. But according to the very aggressive brain and systemic reanimation, after that acute phase, we know that a lot of patients will have a bad prognosis at that subacute phase. If the patient show that after that, if the patient will have a bad prognosis, we make a very aggressive withdrawal of life-sustaining support too. So after that subacute, after the acute phase, we make terminal extubation to call the team that cares for that, to speak to the family. Okay, we have 1 week, 3 days, 3 weeks, I don't know how much time. We treat the patient. Now we are completely sure that the patient will have a bad prognosis, not vital bad prognosis, but functional bad prognosis. So now it's time to withdraw the care because we don't want to have a vegetative patient. So it's time to withdraw completely the care and not to treat the next pneumonia, not to treat the next pulmonary embolism, and to withdraw the care in order that the patient continues to that.
Andrés,
yes,
we need to thank you. We need to stop because we
Yes.
are 25 minutes over. Thank you. So I will ask to Claude and Jose Ignacio to summarize, and we need to close. Thank you for being 1 hour, almost 1 hour and a half. Thank you. So Claude and
No,
Jose Ignacio.
this is great. If I may go first, since I may have to go to the ICU, but thank you so much for the great discussion. I think we've heard from all of you. There is some obviously variabilities across the South America, but I think, listening to what you're saying, there is a common thread here that I can summarize compared to what I heard last week in Europe. In Brussels, we were in Brussels also having this discussion with our European colleagues, ICU colleagues, and it looks like one of the main impediments is this neurophobia concept, right? That people don't understand the brain and they're afraid of the brain and they don't want to treat these patients. They think that everything that has to do with the brain is bad. And so I want to thank you all for contributing to moving the needle from neurophobia to neurophilia. So thank you. Thank you so much for doing that.
Gracias.
Okay.
Claude?
So the first word in World Coma Day is world, and that's why this session is so important. And I learned a lot, and hearing your perspectives, I think, is really key. And it's really interesting to hear how similar they are to those that were expressed in the Asia section and in the Middle East and North Africa section that went on a few hours ago in World Coma Day. There are differences in culture, there may be differences in resources, but we know we're treating the same diseases and many of the challenges are really the same. I appreciate the work that's been done on the registries here, because I think that that's really moved things forward. And I sense a bit of frustration. But here's what I'm going to say. It's what I call good frustration. We recognize that our patients have more capacity for recovery than we used to appreciate, whether in the acute setting or in the long-term recovery. But we have challenges with regard to resources and sometimes challenges with regard to decision-making in different cultural settings. And that's a good frustration because it means we are moving things forward rather than just accepting the way things are. And so I want to thank all of you for this session because it's been very enlightening. Thank you.
Okay, thank you. So Claude, now we have 3 new words in our vocabulary: neurophobia, neurophilia, and good frustration. Interesting concept. We need to discuss it. So thank you, everybody. Thank you for your time to be. I know that a lot of people, as we say at the beginning, leave some things aside for be here and discuss and contribute. Probably next year we need. It is Adrian. It is not because of me. It is because the society, NCS, and Claude, that with David and other people in the organization contribute and create for this year, that the chapters take this space and discuss. That I guess is better at this time that a PowerPoint presentation or a slide. So better is the discussion. So thank you to NCS, Claude and David, and thank you all of you. Ciao.
Gracias. Chao. Hasta luego.